All right. Since it is 12 o'clock and we've got a jam-packed agenda and I would like to be mindful of everyone's time, we will go ahead and kick this off. My name is Chelsea Biggerstaff. I am the Peer Policy Fellow with Recovery People. My co-hosts, lovely co-hosts, would like to introduce themselves. Elizabeth, you want to go first?
Sure. Hey, everybody. I'm Elizabeth Henry. I'm the Director of Policy for Recovery People. I'm also going to be monitoring the chat. So if you have any questions, please feel free to pop them in the chat.
Sherry?
Hi, I am Sherry Layton. I'm the Director of Public Policy for La Hacienda Treatment Center. And I also am the immediate past president for just a few more months for TAP, the Texas Association of Addiction Professionals. And I'm also a board member for ASAP, Association of Substance Use Programs.
And Cynthia. Oh, you're on mute, Cynthia.
You'd think we'd learn after 5 years of doing this to take the mute off, but hello, everybody. My name is Cynthia Humphrey, and I'm the Executive Director of the Association of Substance Abuse Programs, and we meet and we basically represent the organizations that provide substance use prevention treatment.
All right, thanks everyone. To that point, TAP, Recovery People, and ASAP have over the past few months joined forces to bring you a few of these updates from the 88th legislative session in terms of bills that have been filed, bills we were following and working on. So we thought it was only appropriate that this brown bag advocacy session, we would bring you sort of updates of what happened, results of all of these bills, some that have passed, some that have not passed, and where we go from here. That being said, I'm going to go to the next slide, and we will have Cynthia kick us off with funding update.
Great. I don't know how many on the call work for an organization that receives state funding for either prevention, treatment, or recovery support. But because of that, funding has basically been a perennial, is that right? Perennial priority for our organization and basically for the field in Texas so that we can expand the availability of safety net services. So funding is a chief priority. We do not receive a lot of state funds. Most of our funding comes from the federal block grant. But we had a very unique situation this year as we entered into the whole legislative appropriations process, which starts at the state agency level. They have to develop their budgets. And that is that we basically had a big bank balance of money, meaning there was a lot of money left unspent from previous allocations. That seems counterintuitive because we've got such a dearth of programs across the state that people can access. But that's the case. And there are many reasons for that. A lot of it has to do with the fact that we're paid so poorly and that basically we're paid below cost. And so it's getting to be a real crisis situation for a lot of state contracted providers. And so what we were trying to do is kind of take both of those situations and put together a resolution, which would be to fund a rate increase from those unexpended dollars. And so the state agency, we've been working with them for several years, put together the subdivision of the state agency, put together a proposal that said, out of funds already allocated, in other words, those funds sitting in the bank account, they proposed a rate increase. And they studied it, and there's a historic kind of what they call carry forward dollars. And they believe that they could continue to make, they could continue to fund that rate increase going forward based on that historical carry forward amount. So what we tried to do was, I forgot the most important part. So the subdivision put that proposal in, and it was rejected by the leadership at HHSC. And so it creates both a problem in terms of unspent dollars. If we don't spend them, we're going to have to return it back to the feds. And we've got, basically a very fragile safety net infrastructure who can't, afford to really continue treating state patients if we don't get a rate increase. So that rider that we had submitted, very simply said, thou shalt fund those rate increases. However, that was not the rider we actually got, but we did get a rider, and it did accomplish some important things. One is that it's going to make HHSC move on dealing with our rate issue.
Cynthia, I think you went on mute. Cynthia, I think you're on mute.
Have I been unmuted all this time?
No, rate increases.
Okay. So anyway, we got the rider. The rider does a couple of things. It basically says that HHSC must look at a rate setting methodology. Unlike any other healthcare service across HHSC, we do not, in the SUD treatment area, have a rate setting methodology. So any increases we have had has just been on top of a rate that was never based on cost. So they have to set up a rate methodology, and they have to propose that by October of this year. That does not mean that a rate increase or a rate methodology goes into effect by October, but it starts the public process of getting those rates looked at. And so in that sense, we were pleased that it's going to get the agency to move on a rate increase. And that's basically our biggest kind of what we worked on for the appropriations process. So just in terms of funding, I'm not going to go into detail across all of behavioral health, but I think in the slides I did put down what our allocation for the year is. And basically that's not an increase. And the funds move back and forth a little bit based on some federal funding, but that basically is a maintaining service levels from this biennium to the next biennium. Should I move on to prevention or see if there's any questions? We're going to wait till later.
I don't see any questions actually right now, but we will, thank you, Elizabeth, for putting that in the chat. We will have time at the end of this session for questions. So if you have any, please feel free to drop them in the chat as we go along. And yeah, Cynthia, if you want to.
Sure. So prevention, I don't know how many on this phone call are actually, do provide prevention services, but the state funded prevention services that are offered in Texas are primarily school-based programs. And we've been doing evidence-based prevention programs for almost 2 decades. The other health and human services are just now catching on to risk and protective factor programs. So we work with our mental health partners to basically look at how can we kind of better address the kids' mental health needs or the risk and protective factors that make them vulnerable to a wide range of behavioral problems. And the decision was to try to say, instead of is to set up a mental health, a dedicated mental health allotment to school districts, which would be similar to the school safety allotment. We've got lots of situations, and I'm not going to go into, I never can remember ESS. The COVID funds that schools have been spending for mental health are set to expire at the end of this year. And so basically those funds and what they've been using to help address some of the kids' mental health needs based on COVID, increased suicide, those funds are going away. Unfortunately, the legislature decided not to address any behavioral health needs in schools. And that is unfortunate. So we did not get any movement in that area. There was a school safety increase, an allotment in the school safety fund, an increase of about $300 million that can be spent on mental health or behavioral health programs. It's not exclusive of that, but also in the bill that funded that $300 million increase, House Bill 3, they're also requiring certain fiscal safety standards be met. And school districts are basically saying, in order for us to meet those physical safety requirements that the legislators put forth, there's going to be no behavioral health funds remaining. And so we're disappointed about that. But we will continue to see how we can, improve the situation for kids, because I think it's only going to continue to increase. I also just wanted to note, we do a lot on trying to get bills passed, but sometimes we work to get things in bills not passed, things that are not particularly good. And so we paid a lot of attention to Senate Bill 595, which was it's about parental consent in the schools. And there was a proposal that was an amendment that basically said, if you're going to do mental health, psychiatric, it was couched under psychiatric and psychological services, but the definition of that would sweep up our prevention programs, a whole wide range of programs, because it basically said, if you address their attitude, how they're doing, if you do anything that talks about the kids' emotions or mental state, you would have to have parental consent for each activity. Well, if you've ever tried to get parental consent to do a program in the schools, it's an administrative nightmare to get one. And we do our programs are done in like a series of, the program is 10 weeks with 10 different, curriculums or daily program agendas during that program. So you'd have to get it for each one of those activities, whether it happens once a week, every day, etc. So we worked on that. And while we were biting our nails to see that some bills did get passed, we were also biting our nails to make sure that one didn't. And it didn't. So we were happy to see that not pass. I guess the other thing in prevention is we get into our fentanyl related area. I know I have to eat my words on this, because as we walked into the session, I was almost positive, because the governor had kind of endorsed fentanyl testing strips as part of the strategy to reduce overdoses. And it was just chugging along well. There was also about, I think someone said 28 bills that were introduced along those lines. It seemed to be kind of a foregone conclusion that we would probably end up with making fentanyl testing strips legal. However, it didn't pass because it got stuck in the Criminal Justice Committee on the Senate side. Chairman Whitmire, there were 4 votes against it, again, with the same kind of old trope that they've been used, is that if they test for it, it's going to increase their drug use. So it didn't get out of the Senate committee. And that was a disappointment to many people, because it looked like a foregone conclusion, but it stalled and didn't pass. Again, as related to the overdose situation, I don't know how many of you have worked with any of the HIDA or have worked with the overdose mapping tool that's available that they created, which creates kind of a real-time tracking of overdoses. We basically now have a bill in place that the public health authorities, or the public health districts, I should say, or law enforcement, basically in the regions, will now enter overdose information into basically a real-time mapping computer software. It doesn't mention this software by name. We just happen to know that that's the software that basically motivated this bill. And so we see that as a good thing, because now law enforcement or public health will have an incident of an overdose, whether it's the public health authorities that get the information or the law enforcement's response. They have to enter that information into this system, which will pop up a real-time map, allowing the state to see where there's a high prevalence or where there's a spike. There is no identifying information that goes into that. It's just where the overdose occurred, was Narcan administered. It's very general information, and where the overdose occurs is kind of geographic. It's not by address. So we see that as a positive, which will allow us to kind of command resources into those areas that need education, need services as spikes occur. I think that's it.
Thanks, Cynthia. Sherry, up next with treatment updates.
Thank you. I think the overriding lesson of this legislative session was don't make foregone conclusions.
Yes.
There were a number of things that we thought, man, we've got great momentum. This is going fast. This is going forward. And boom, it blew up. I see several of y'all on the call that were active at Recovery Day, that were in several of you, I called on after Recovery Day to help me work some bills with specific committee members. And I thank you very much for that. There was great response. We worked these bills really hard, or at least 3 of the 4, we worked really hard. And unfortunately, none of them passed. So I will hit the bills. I'll tell you what we know about why they didn't pass and what we kind of hope to do from here. So HB 233 was our in-service training on abuse, neglect, and exploitation. This applies to you if you work in a licensed residential substance use facility. And there were, so that one had great momentum. It passed out of the Public Health Committee unanimously. It passed the House unanimously. It did get stuck for a long time in the Calendars Committee, and several of you at Recovery Day went in and dropped red cards in the Calendars Committee. And then it got referred to the Senate Health and Human Service Committee, and then it stopped. If you've paid attention at all to the news in the last 3 months, you can't help but understand that there's a lot of tension between the House leadership and the Senate leadership. And sometimes our bills are the victim of some of that tension, unfortunately. And so sometimes things get, we think they're happening and then they just stop moving. They just get stuck. And so we had that happen with 2 of our bills. HB 248 was the other one that happened to. And both of these, 233 and 248, this was our second session to try to get these bills through. And so HB 248 was our to strengthen our existing ethical marketing practices and patient solicitation laws that would have updated those for things like internet, the prevalence of intensive outpatient programs, those kinds of things. And that one also passed the Public Health Committee. It got hung up in calendars for about 6 weeks. Then it passed the House unanimously. It went to the Senate. It passed out of the Health and Human Services Committee unanimously. It got placed on the local and uncontested calendar in the Senate. And then it got taken off the calendar in the Senate and it never got voted on. You talk about wanting to beat my head against a wall. So frustrating. I'm just not sure how much closer you can get to getting something passed. With both of these, these were just products of just the Senate work doing, the things coming over from the House to the Senate, things, and then just getting stalled out at the end of the session as they kind of get focused on other things. So a lot of frustration. Everybody told me it takes 3 sessions to get something passed, and the competitive spirit in me goes, oh, you just watch, but probably going to take 3 sessions. So I eat my words. But we are hopeful that those will get passed next session. And then there was 2 bills that came out of the parity strategic plan that was developed between 2017 and 2021. And HB 5121 would have expanded federal parity requirements to Texas state employees, public school teachers, retired teachers, and UT and A&M system employees. And it would have said that they would have to comply with federal parity requirements. And it also would remove some outdated limitations that we have in current Texas insurance law. And this one was rocking along pretty good, and it actually passed out of the House and again was referred to Senate Health and Human Services, and unfortunately it did not get a hearing. This was our first time to file this bill, and it was filed very, very late in the session. And so actually I was really glad that it made it as far as it did, and I'm hopeful that we can get it filed next session as well. HB 5230 had two pieces to it, and it would have prohibited commercial insurance plans from requiring prior authorization for medications to treat opioid and other substance use. If you work with health insurance, you know sometimes that prior authorization process can take several days, and sometimes we lose the opportunity to work with somebody and get them. You know, we lose that opportunity where motivation is high. And so we wanted this to pass. It also had an element in it. We had a 4-year period where this prohibition for prior authorization was implemented in Medicaid, and that was set to expire on August 31st of this year. And so we had a piece in this bill that would have removed that expiration date and made that prohibition in Medicaid permanent. This HB 5230 was scheduled for a hearing in the Insurance Committee, but the Texas Association of Health Plans, which is a really big dog, when you're, in a fight, it's a really big dog. And they said, we're going to oppose this bill because, we just don't like things that say that tell the insurance companies what they can and can't do. And so the insurance company took it off the calendar, and we decided, it was, again, this one was filed late in the session. And we know that that we are going to have to work in the interim period with the Texas Association of Health Plans to find a compromise for them. And it's hopeful, though, because they worked out a compromise. There was a similar bill that disallowed step therapy for medications for serious mental illness. And it was also a bill that came out of recommendations from the Parity Strategic Plan. And that bill, they were able to work out a compromise with the Association of Health Plans. And so that bill passed with the allowance of one trial for an alternative medication prior to, generally speaking, you're getting into the more expensive medications that become the issue. So we know that there's some opportunity for compromise, possibility with that we can look at get going into next session. And then the other good news in that was there was a separate bill, HB 1357, that simply removed the expiration date for that prohibition from prior authorization for Medicaid. And it was an example of sometimes we put pieces into two different bills so that if one makes it, one doesn't, then we still get that progress. And so that bill passed. So the expiration date was removed from Medicaid so it is permanent that Medicaid is prohibited from requiring prior authorization before a doctor can start medications for opioid or other substance abuse treatment. So those are, lots of stress in my life the last week or two of session, in thinking, oh, we're going to get there. Oh my God, no, we're not. But we, we'll do it again. I think that's it. I think that's my last one, Chelsea.
Thanks, Sherry.
Chelsea? I also just wanted to add, I didn't bring this in, but we've been working on it for several sessions now, but HB 12, which was a Medicaid extension for moms up to 12 months postpartum, passed. And that's very exciting. It's particularly of interest to those of us that provide specialized female services, especially pregnant and parenting programs.
Yeah, absolutely. Someone who
Chelsea, Before we move forward, I just wanted somebody at Natalie asked about would HB 5121 only cover medication treatment for substance use disorders? Yes, it was specifically focused on medications. And so that was, so yeah.
I think part of the question was, is it inclusive of said recovery support services or just treatment?
Well, it was specific to medication. So it was prior authorization for medication for treating opioid or other substance use disorder. So, it was insurance coverage of the medication.
Thanks, Sherry. There is one more question in the chat, real briefly. Elizabeth, if you want to answer before we move on to recovery. Hannah, I did not forget you. It finds it really quick. In terms of school behavioral health, did recovery people have a position on Senate Bill 763 regarding chaplains in schools?
So one of the things we have to be really careful about is staying in our lane and staying within our scope. And this one was just outside of that scope. I will tell you that through the Texas Coalition for Healthy Minds, there were quite a few organizations that were working on that bill, and to varying degree of support or opposition. So that's definitely one place where we at least get to stay updated on what's happening in other people's avenues. But no, we did not officially take a position on that bill. Great question, though.
Thanks, Elizabeth. All right, and our recovery part. So first up, one that we have talked about all session because it has been obviously a driver for recovery people, has been House Bill 299 by Murr that was related to creating a voluntary accreditation to recovery housing. So what that bill does, most everything that we wanted it to do was define recovery housing in statutes. In fact, actually, there is a link, I believe. Elizabeth, do you have our, let me see if this should be, are you dropping it in the chat? Do you want me to?
If you have it, can you drop it in the chat? I have to go through Canva to find it.
This should be, hopefully, a bit of, as this bill is quite lengthy, which is good. So that document is sort of the breakdown of what actually ended up in 299. So it does define recovery housing as a shared living environment that promotes sustained recovery from substance use disorders by integrating residents into the surrounding community and providing a setting that connects residents to supports and services, promoting sustained recovery from substance use disorders that is centered on peer support and is free from alcohol and drug use. That's really important because prior to this legislation, we had no definition of recovery housing. It's kind of up to interpretation. So yes, thank you, Elizabeth. This will also be uploaded on the webpage as well. It does do a few things in terms of directing Health and Human Services. It would require Health and Human Services to adopt minimum standards for accreditation for recovery housing. Those accreditation standards need to be consistent with the quality standards for NAR, which is the National Alliance for Recovery Residences, or Oxford House Incorporated. Yes, thank you, Leah. The entities that Health and Human Services may approve to serve as accrediting organizations are also limited to those particular organizations, so NAR and Oxford House. And it also details the types of facilities that are ineligible for accreditation as a recovery house, and requires them to adopt standards to prohibit accredited recovery housing from providing personal care services defined by the Assisted Living Facility Licensing Act, excuse me. And one of the biggest pieces that I think it does for Health and Human Services that will be really beneficial for all of us, I don't know if there's any researchers here or data enthusiasts, but it does direct Health and Human Services to provide an annual report over accredited recovery houses in Texas, which is super influential because if any of you are like policy geeks, you know that policy is driven by data. So that information, future information, is going to be extremely relevant and helpful in crafting future legislation. Yeah, data equals dollars. Excellent point, Elizabeth. Some of the specifics around the details for the accrediting organizations and the houses, specific recovery houses. A recovery house that is accredited only by NAR is required to have at least one individual serve as a responsible party that oversees the administration for the house itself. They are also going to be, that person is also going to be responsible for getting trained and meeting specific training requirements, as well as notifying the accrediting organization, so either NAR or Oxford House, if there are any changes to that specific party. Recovery houses that are accredited under this bill shall also not allow a designated responsible party, employee, or agent or recovery housing offering to pay or agreeing to, this is very specific to solicitation and advertising any false, misleading, or deceptive information. It prohibits houses from doing both of those things. So back to the patient brokering that Sherry mentioned earlier, this is kind of an additional piece in this bill that would specify that for these houses as well. And then the accrediting organization will also be required, to establish the, don't broker, don't deceive people. They will also be the approved accrediting organization. So again, NAR or Oxford House will be required to establish their accreditation requirements that Health and Human Services will actually then adopt. They will establish their procedures. Most of these things have already been done, but by these organizations, but just like I said, in the details. They will also provide training to the recovery house parties, as well as develop a code of ethics and provide information to Health and Human Services for that annual report that I mentioned earlier. The organization itself shall actually be allowed to enforce those through either, suspension of an accreditation for a period no longer than 6 months while they conduct an audit for that particular house or houses. And then once the audit's complete, they will be allowed to implement a corrective action plan or revoke the accreditation altogether. Some really important dates around this one is that since this bill has passed, it will take effect September 1st, 2023, barring, we get past the 19th, we will, I say so. That is the date that the governor has to veto any particular bills that he deems. And then also a really important piece to this legislation as well is that effective September 1st, 2025, the bill will prohibit a recovery house that is not accredited from receiving any state funds. So sort of incentivizing the recovery housing accreditation process. I know that was a lot. Like I said, we provided some information over that, but if there are any questions, obviously, please feel free to reach out to Elizabeth or myself. We spent a good amount of this last session working on this particular bill. Up next, though, we have a couple of bills back to relating to opioid antagonists. This a lot of times can also fall under prevention, I would say, as well. But Senate Bill 629 by Menendez, actually related to the maintenance, administration, and disposal of opioid antagonists, Narcan, naloxone, any other particular opioid antagonists on public and private school campuses, and also to the permissible uses of money appropriated to a state agency for the opioid abatement account. So this bill also has quite a bit of detail to it. I consider this a pretty big win for our schools, because one of the things that has been so important to our recovery community in general has been the expansion of access to Narcan and naloxone in just various spaces. So the fact that this has passed now basically says, Senate Bill 629 says that a policy will be implemented by school districts that work with children ages, grades 6 through 12, public school districts, but it does give, it requires school districts, public school districts, and allows charter or private schools to also adopt their own policies regarding this. But so that they will actually be able to, state school personnel and volunteers will be able to be authorized and trained to administer Narcan to a person experiencing an opioid-related overdose. It also requires each school campus to have at least one authorized and trained person on campus at all times during their regular school hours. It establishes the number of opioid antagonists that should be available at every campus, and also require that the supply of Narcan at each school campus be stored in a secure location that is easily accessible. It also requires Health and Human Services to consult with the Commissioner of Education to adopt rules on school campuses with a policy date of no later than November 1st, 2023. And those rules that they're establishing need to include the process for checking inventory for Narcan, as well as the amount of training hours required for personnel or volunteers to go through that process to be able to administer the Narcan. It also, this was one that also kind of touches on that reporting piece that Cynthia talked about earlier. And it does require a school to report any details of the administration of Narcan within 10 business days. But that report looks pretty similar to what Cynthia mentioned in that overdose reporting as well. So it is still anonymous. There's no name or, physical address of the person that received the Narcan, but it does include the age of the person who received the Narcan, whether the person who received it was a student, a faculty member, a volunteer, or a visitor on the campus. It requires the physical location where the Narcan was actually administered on school, the number of doses administered, and the person or the title of the person who actually did the administration. So again, it's pretty detailed. And like I said, back to that reporting drives, our funding streams. So that's all we think really worthwhile information to collect. The training also needs to include recognizing signs and symptoms of an opioid-related drug overdose, which is, I think, really great for any sort of education piece. How to administer a Narcan just in general, as well as how to follow that up with any sort of emergency procedures if needed. So CPR or anything along those lines, as well as how to properly dispose of any Narcan. Training has got to be provided either in a formal training session or online, and be in accordance with their professional development policy that each district board has adopted annually. I know that is a lot for that piece of legislation as well, but again, all really good stuff going to our school campuses and expanding the access of opioid antagonists. Maybe the next one, Melissa. Yeah. Senate Bill 867 actually does a very similar thing with way less detail. This bill, I believe, was actually only a paragraph long, but it relates to opioid antagonists under who can actually receive that under the opioid antagonist program that is currently authorized by Health and Human Services. So this particular bill just adds institutes of higher education, so colleges, into that program as well that's already established. That bill, as well as the previous bill, both take effect immediately, like I said, barring we get through, the 19th and the governor doesn't veto anything. And lastly, Senate Bill 1796 and House Bill 4678 by Menendez on the House side, the Senate side, Bryant Lalani, relates to establishing a social worker recruitment and retention program administered by the Texas Higher Education Coordinating Board. Now, this may seem like something that has absolutely nothing to do with what we're here to talk about today, but the reason I wanted to include this one in the slides is because this particular bill, this one did not pass. In fact, so this one didn't pass, but it would have established a social worker intern practicum stipend. So SWIPS was the shorthand for that. That would have provided stipends for social work interns who are currently going through their practicum hours. The priority criteria would have also, it would have been priority criteria for individuals who qualify for need-based aid and have a placement that fell into a mental health shortage area. If you follow that right now in Texas, that's pretty much all of Texas. And it would have established a base hourly pay for practicum hours. Like I said, that may seem like it has nothing to do with our field of interest or why we're here. The reason I wanted to bring this up is because this is an example of legislation that was crafted and presented that gets people like us thinking along the lines of like, how can we do something similar and translate this into something for the substance use workforce or the recovery workforce? So this is something that we've looked at and already started brainstorming around. Is this something similar that we could maybe try and look into creating stipends for placements for, peer support or, other internships along the substance use lines? So that's just an idea of where our brains are kind of going with things, which leads me into our sort of next segment that Elizabeth, I think, is going to talk a little bit about, and that is what's up next.
Kelsey, can I throw in, since you're talking about the social work stipend, can I throw another one in there that did not pass?
Absolutely.
HB 1879 would have allowed LPC associates, LMFT associates, and LMSWs to be reimbursed under Medicaid while they were fulfilling their supervision practicum requirements. So the state sees them as licensed, but they're in a 1 year or 2 year period. I think with social workers, it's a little longer than that, in getting, in removing that associate or moving from an LMSW to an LCSW. But that and the social work stipend, those are both, the state working to address the workforce shortage in behavioral health care. And unfortunately, neither one of those passed, but it was trying to make more practitioners available to work with individuals.
Yeah, absolutely. And that is, something that kind of sets us up for where we're going now.
Sherry, what was that bill number?
HB 1879.
1879. Thank you.
Angel Landrum has also commented in the chat box that there was another bill that would have allowed an LPC essentially compact, which very basically would say if you are licensed as an LPC in one state, you could transition that over to Texas pretty easily, much easier than you can do now, which would help, allow for portability and again, just expanding access.
Mm-hmm.
Along the workforce lines also is there was a appropriations increase for the tuition reimbursement program for behavioral health professionals. And that increase was basically $14 million per year of the biennium. So there will be more dollars available since once the program caught on, they spent down.
Oh, I think you froze on us, Cynthia.
I will add to what Cynthia was saying, in that those are state-based student loan forgiveness programs. So there's also federal student loan forgiveness programs. And generally speaking, to qualify for those programs, you have to work in an eligible organization. And if you want information on how to get your organization as an eligible organization, so your employees could qualify for some of those forgiveness programs, on TAP's website, under workforce development, they have contact information for the HHSC has a staff member that's focused on that.
Excellent. Thank you, Sherry. So now that session is over, what do we do with all this stuff? You know, I think one of the things, and I Chelsea mentioned this, and really Sherry and Cynthia hit on these things too. Even though a lot of this legislation didn't pass, a significant amount of legislation that we were really hopeful would pass did not. It still set a precedent, and it still started conversations, and we still were able to meet with offices and educate and bring more awareness to these issues. So just because it didn't pass right now does not mean that we're going to stop working on it. If anything, on some of this stuff, we're just going to double down on it. And also during the interim, which is this 18 months that we're in now before the next legislative session that starts in January of 25, during the interim, now is really the time to start educating our policymakers and bringing these things to their attention and telling them what the solution is. It's great that we all know what the problem is, but if we want something solved, we have to bring the solution also. And so, you know, funding, none of us have enough money ever, right? I'm just kidding. None of us do. Prevention, treatment, recovery, none of us have enough money. And so it sets up some interesting competition between programs, right? Because of that. So thinking about what kind of funding your organization could use, what kind of activities and programs that your communities really, really need to have or need to have expanded, now is the time to start having these conversations. We have an opportunity next summer to submit what is called a legislative appropriations request exceptional item. Lots of words there. Basically, it is a document that is created, given to Health and Human Services, that an organization says, we want this amount of money to be used for these things, and we think you should allocate it. So those are due early next fall. So if we want to start having conversations about money, now is when we need to have those conversations for the budget that starts in 2025. So it kind of seems like, well, we just finished session. Well, now we've got to start planning for the next one. And that's one of the ways that we can be a lot more effective in trying to put a voice behind these things, is by starting now and not waiting until right when session starts or right before. Sometimes at that point, deadlines have passed and it's too late. So on that note, we really, really want to encourage you guys, just like with ABCs of Advocacy and Recovery Day at the Capitol, to meet with your legislators. As soon as special sessions are over, and hopefully they won't last too long, but as soon as the special legislative sessions are over, your representatives and senators are back in your district. They are back in your area. And this is the time, during this interim time when things are a little bit slower at the Capitol, this is the time to invite them out to your recovery home. Have them come out to your RCO, have them visit your treatment center, bring them to a TAP meeting, like bring them out into the community. And I know when Chelsea and I have done this with staffers in legislative offices, they've loved it. It has been eye-opening for them to see what it is that we're asking for in the works as it happens and unfolds. So that's a really powerful thing that you can do as a constituent to engage the legislators and their staff that are in your district. And by building those relationships as we move into the legislative session in 2025, they know who you are. They know that you're the subject matter expert and what it is that you do. And that is very valuable to them, to be able to be the voice and that resource. Let's see. One of the things that we mentioned in the chat that I wanted to bring up to you guys was I'm getting a lot of questions around more information on the implementation of the Recovery Housing Accreditation Program. And kind of like Chelsea said, we will know more about that later in the summer, hopefully. So until the special sessions are over, things are at a little bit of a standstill. Really, until we get past June 19th, we're very optimistic that nothing's going to happen to this, but still, that's the date that a lot of our state agencies will wait for. They need, before they can start moving, they need to make sure that this is going to stick. And so then we can start having conversations as a community with our state agencies around what implementation looks like. It falls on us as community members to make sure that our state agencies know what this looks like in real life and to help them implement things in an effective and efficient way. So they very much rely on us to help with that stuff and to provide feedback on that. So on that note, Recovery People will be hosting, or Trone will be hosting, a statewide recovery housing meeting. It will probably be late August, September. We're hoping not to interfere too much with Recovery Month because we're all pretty slammed in September. But the reason why it's later is because we need to see what this could even look like with Health and Human Services and what resources they're going to use to work with this. So for the questions of when we were doing that, that's why we didn't get more involved into that right now, because we just don't know what that's going to look like. But on that note, I'd like to open it up. I'd like to thank Cynthia and Sherry and Chelsea for being here. It's great to have the band back together. I just absolutely love working with you guys. If anybody has any questions, please feel free to put them in the chat or use the raise your hand feature. We still got a few more minutes to the top of the hour.
Justin. Oh, hang on, Justin. You're not on mute, but I can't hear you.
Can you hear me now?
Yeah, there you go.
Okay. The one expanding or extending coverage for pregnant women for the 12 months. Can y'all go over that one again?
It's this. Am I on mute?
No,
No.
you're good.
Good.
It's basically it's extending the coverage. Right now, Texas does cover for those who qualify, Medicaid through pregnancy and 6 weeks after delivery, and then it stops. And this basically just expands the eligibility for continued Medicaid coverage for 12 months instead of 6 weeks.
And that passed, right?
It did pass.
Well, I'm glad something passed. Okay.
Yeah,
Yes, I
right.
thought that was a big win.
It was. We worked on it, for several years. Of course, Texas had one of the highest maternal mortality rates. It still struggles with that. And one of the contributing factors has been overdose.
Right. Okay. Yeah, that'll be great for us. All right. Thank you so much.
Yeah, it's not a complicated bill. It's only about, a paragraph long. It just says the eligibility is extended to 6 months. To 12 months.
Anybody else have any questions over maybe anything we talked about or any other bills that maybe you were interested in following throughout the legislative session?
Hi, this is Abigail with Sakata out of San Antonio. And I just want to encourage everybody on the OD mapping bill. I got a call from one of the regional director here in Texas from OD, from the folks that put it together, the OD mapping. I just lost my train of thought. The high drug intent, HIDA, yes. So because the language doesn't specify that it is the HIDA OD mapping, cities and counties can choose to do something else. So for example, here in San Antonio, we're going to really have to fight that they do use OD mapping, because we have folks here in San Antonio that probably would prefer not to use it. But in order to be able to look at our state as a comprehensive and then compare it to what's happening with other states, it's a good idea to use the same system, and it's free. So anyway, I just want to encourage everyone, and then reach out to your HIDA folks if they can support you in any way, in trying to encourage the police department and fire department and other first responders to utilize the OD mapping as the overdose data center.
Excellent. Thanks, Abigail. Let's see, anybody else? Questions, comments? Well, thank you guys very much for being with us today. We really appreciate your time. We know it is very valuable. Again, if you have any questions, please feel free to reach out to any of us.